Good morning and welcome to our monthly live peripheral endovascular case from Mount Sinai Hospital here in New York City from the Department of Endovascular Interventions here in the cardiac cath lab. So we're here again today, the last Wednesday of February, for another exciting case led by Dr. Christian and Dr. Guja. So without further ado, good morning, PK. Good morning, Dr. Guja.
Good morning, Dr. Kapoor. How are you?
Good, how are
We just
you?
maybe ask you to pull up your tie a little bit, Thank you, thank
Oh,
you. I really
sorry about
appreciate
that. The
it. A
run
little
was
bit.
good.
Yes, that was very good color combination. No. I'm all kidding aside. Welcome to the Cath Lab. Dr. Guj and I were commenting on your wonderful sense of style today. I think you look phenomenal. And dashing as always. And I know the audience loves your dress. We get comments all the time about you and Dr. Guja. So that's good. But clearly we have a very challenging case, courtesy of our good friend Dr. Guja. But let me introduce everybody. All kidding aside, we're so happy to be able to present these cases to you. I would like to thank all of our supporters, especially who give us grants to be able to do these cases that are hopefully educational. We have a really good case here. But first, let me introduce our team. Obviously, everybody knows Dr. Guja to my left. He's the director of endovascular services at Mount Sinai South Nassau, associate director here and an integral part of our team. To my right is Dr. David Song, who's our endovascular fellow. I'm proud to say he'll be joining us next year as an attending. We're looking forward to working with him for many years to come. Behind Dr. Guja, again, and somebody who needs no introduction, Ray Lascano. I call him Dr. Ray. Wonderful, and he's incredible in terms of his ability to understand vascular patients and understand the processes that we do. We have Elizabeth Holton, our nurse, Damien Cabrera, and who's the other? Who's our Ramon, our other tech, who I didn't say hello to this morning. We have our incredible AV team who's here, and without further ado, we have a wonderful case to present. David, can you please?
Yes. Good morning, everyone. This is a very challenging case of a bilateral osteoiliac occlusion. Our patient is a 77-year-old gentleman referred for lifestyle-limiting claudication, progressive to ischemic rest pain, left greater than right, with less than one block of activity, Rutherford grade 2, category 4. He has multiple comorbidities we commonly see in this patient population. He has CAD, he's ESRD patient, he's hypertensive, hyperlipidemic, he has aortic stenosis, and he has paroxysmal AFib on anticoagulation. He is on good medical therapy. He's on anticoagulation with Eliquis, which we held prior to this procedure. In terms of his non-invasive diagnostics, he has very severely diminished ABIs bilaterally. He also has monophasic waveforms and also bilateral monophasic waveforms in the CFA indicative of iliac disease. We have arterial duplex from an outpatient lab as well, which demonstrates that he has multi-level severe significant stenosis at all levels. We do have a limited diagnostic peripheral angiogram from the outside, which shows this severe bilateral aortic, almost bilateral osteoiliac occlusion with reconstitution of collaterals distally. We did get axial imaging, so we have a CTA abdomen and pelvis, which really demonstrates what we're seeing.
Does it play or does it not play?
Yes, it does.
Oh, good.
Hold on.
So this is very important. I just want to go over this. So it shows severe atherosclerosis of the aorta, occluded renal artery. I believe it's the left, if I remember right.
Yes.
And I looked at it this morning, and then you have bilateral ostial common iliac lesions. Important in planning because you need to understand the sizes of the iliacs and the sizes where the reconstitution zone is, and also more importantly, what technique that you're going to use. So when you look at the aorta, it's diffusely atherosclerotic. I think the IMA is also gone. And then so you have this huge, robust collateral. It looks like a lumbar collateral coming down and supplying the internal iliac on one side. You also have, severely calcified right iliac, aneurysmal left iliac. So that's also going to help me to understand how we're going to cross this, because obviously in the right iliac, it's concentric calcium, very small lumen, occluded lumen, but small. And so we have to be careful about rupture on the right side. Left side crossing may be an issue because of the aneurysm. We don't want to perforate the aneurysm and create bleeding because it's occluded, but it's aneurysmal. Then the other question is about embolization distally. So the distal runoff shows here, and you can see here severe infrapopliteal disease with proximal occlusion of the anterior tibial and distal occlusion of the perineal, and really one vessel to the foot. His atrophy kidneys, so the renal function is not an issue, and it helped us with planning this case. So we decided to do this anticoagulation-wise on heparin. Dr. San got radial access. We went up and over. Go minus, David, on the pictures. So we went up and over, and we did an aortogram, minus. So we did an aortogram, and let's see, there you go. Karthik can do it. So the aortogram here showed exactly what we talked about. Again, you can see that's a huge lumbar collateral giving rise to the collateral going to the internal iliac on the right, and then you see on the left. But again, you can see it doesn't look bad, but you can see in the negative contrast, it's severely calcified, and it's very aneurysmal on the right. And listen, we're going to have a low threshold to call it if it's looking unsafe, because there's really no area for a CRAB here. It's going to be an aneurysmal fix if we get too distal in the aorta, but if we're appropriate, we appropriately cross, we could fix this with BBXs. So right now, planning-wise, we got bilateral 8 Frenches down below. Karthik, go next. We'll show you the picture there. So here's an 8 French, and then I don't know what that little jet is. It's not a bleed, I know that. Then next, then you can see here you've got a bilateral 8 there. There's your occluded segment here. It's a flush occlusion, and on the other side, Karthik will show you. And there's the other flush occlusion. So what I did now, Karthik and I have gone up. We've got a Terumo stiff angle glide. Karthik wanted to go with a 018, but I figured that with this kind of lesion, we'll be able to get through with the stiff angle glide. So I'm going to have Karthik just give me a little. Let me just get it back in position here, and then let's see if the wire kind of sneaks through. Why is he moving his foot, guys?
I mean, just to add on.
Okay, why are you pulling my wire?
Not pulling.
So David is sabotaging me like all fellows do.
So I think to comment, this is not really.
Vishal sabotaging you, right?
This is not really.
Yeah, with his foot, and then he'll pull the wire down with his foot, and then Vishal, there's a lot of comments on your sabotageability. But anyway, I'm sorry to disturb you. Go ahead.
No, I was just trying to say this is not a case for the weak-hearted. I mean, let me put it this way: it sounds very easy. The history was easy breezy, and you have all the modalities. But I think this case really needs a lot of planning, especially for the viewers. Before you start doing these cases, it requires a lot of planning, a lot of multidisciplinary approach. Here at Mount Sinai, Dr. Christian has created a phenomenal integrative approach between our vascular surgeons and IR and interventional cardiology. So we work all in hand. But in these cases, like I said, it's a lot of planning. Knowing what we are getting into is the prime to your success. So like you're getting a CT scan, a Doppler ultrasound, anatomy description, what are the collaterals, what are my bailout strategies, what's my feeder vessels, what if I compromise some floor knots. So I think it's very important to discuss, like Dr. Christian really said, appreciating the collaterals, the lumbars, the aneurysms, the complexity or the complications he could end up in is very important. So Dr. Christian, any specific reason picking right over left or left over right?
I'm just trying to see here just to understand where we are. You can see it's a very badly dissected, occluded vessel there, so which is fine, which we know we're going to have these kind of issues. So, but I'm going to do a roadmap here just to see where.
I think because the left side is and so we thought probably having
one more dye, Ray?
Is better, and also if you see
inject from above and below.
The left side has pretty significant collateral supply from that, and the right is the one which actually has, and even the ABI wise, the right is worse than the left.
No, I just want to, I want to just give a little dye. Ready?
Yep.
Go ahead, inject. There it is, brother. Okay, now give me a confianza here, guys. So so we decided to cross the right because of the aneurysm. Vishal, I think the right is going to be more challenging. Based on this, we always have a bailout of a fem bypass.
Correct.
So we're like, okay, let's try to do this. If we can't, we'll obviously cross. This looks easy, but that's all just aneurysmal, dissected, horrible clot, all sorts of gunk. We have our IVUS team here ready to help us out. We've got our VBX team here ready to help us out. So we've got everybody here. The only question I want to ask you, Vishal, is what's your strategy on these? You go, do you I mean, do you do axial imaging on all these patients? What is it that you do for these type of patients?
No, I mean exactly the same thing like it was done. Get a CTA, define the anatomy, the
that's
calcification, like I was talking about to the audience, the calcification, the collaterals, the degree of aneurysm, and then we can definitely plan. Like you said, in this case, best case, worst case, if we cross, we fix one side, and then we can do a fem bypass. That would also give good relief. I think the targets at the femoral look good, and also on the CTA, there was not much calcification. So, I mean, ideally, like you said, you'll try for both sides, but even if you get one inflow up from the aorta into the right common iliac, and then we could, as a bailout, you could call it, or whatever, as an alternative, is I guess is the right word, we could do a fem bypass. But here you can see, I mean, so you switch your wire to an overnight to find a micro channel to see if you can cross over.
Yeah, I'm just trying to see a 014 here to see whether
014.
we were able to get something. You know, these are always difficult to cross at the level of the ostium, you know, and I'm just trying to get a feel here. So we're just going to have to probe it. We might have to, you know, we might start on the other side as well, you know, in a second. We'll just probe this for a little bit to see how it works. Give us an 018 command here. That may, well, not a command, but Terumo Gold maybe might work here better. This feels real to me. Push up a little, Karthik. Kind of like the way this feels for me. Because I'm definitely engaging with plaque here. Hold on, let me torque. Yeah, there you go. It's just not wanting to go here. The problem here, Vishal, is it's a 3D representation of a 2D model.
Correct.
And the issue here is what's happening and how this thing is behaving. Get us a Terumo Gold, my friend.
That's it.
Okay.
Yeah, I think you.
No, that's not it.
Vishal, do you always start with 035 or how is your?
No, in this case, I understand it's a big lumen. Finding a micro channel is on a lower side, but I would probably, just to be on a safer bet, like you said, a lot of aneurysm, a lot of gumba, start probing with an 014, 018, but I quickly switch over to an 035 if it's not giving it, if it's just spinning in that big lumen vessel and we're not able to engage it.
There you go. That's what
The problem is because of this aneurysm segment, it's hard to control it. So you can start with an 018, like Pika's talking about Terumo Gold or any of those wires, see if it crosses. If not, then you have to switch over to an 035 real quick, especially in this size.
That one is good.
Yeah, this feels really good. There you go.
There you go.
So again, PK was right. I hate to sound like that, but you know, push up, Karthik. You guys, I want everybody.
I have to wake up early in the morning to hear this every single time, so
it's not going, huh? All right, so we're gonna
twist it.
Well, actually, you want to get a let's get a Navicross.
Take the wire up.
Let's get a Navicross. Get us a Terumo Navicross, guys, just to make sure. So I'm just gonna oh wait, it's not moving. Wait, oh boy. No, I'm in the wall. Feels like we're in. No, going now. Show me, brother.
Probably catching a plaque, no?
Show me, bro. Up top, brother. Let's make sure we're in.
We're in.
I don't know, bro.
It's too free.
Feels really weird, bro.
Hold
on. You know what? Actually, you're right. It's very free. Yeah, you're right. You're right. Okay, give us a 018 Navicross now.
018.
I mean, 035. Sorry, 035. Hold on. Let me walk this back.
Yeah.
Here. So we're going to walk this back. I'm certain we're in because the way it felt, and Karthik and I both, it's always good to do this with people who are experienced and who are very good at what they do because, it's like 4 sets of eyes and are very good. 2 sets of eyes, excuse me. So set is 2, right?
Vishal, PK is getting more aggressive as he's getting older.
Last time Liz taught me was set is 2, the 2 items. But anyway, so we're cross on this side. So now the question is we're going to cross on the other side. Once we cross on the other side, God willing, we'll go ahead and get our IVUS ready, our 018 IVUS ready. Okay. Flora.
Taking an 018.
Yeah, it's going to be
Give me an 018 Navicross, please.
Yep, not going to go.
CXI catheter because we have to do a IVUS anyway, so it's 014.
Yeah, 018. Let's do it with an 018. Let's not rupture this.
We're going.
Yeah.
Yep. And that's why one of the reasons I wanted to do Shockwave. Once we get the 018 across, I'm going to put the V18 up. And with the V18, we should be able to go up with everything else. Go ahead. So we got the 018
very
here.
calcified also, I think.
Very calcified. CT-wise, very calcified,
we
brother.
took a dry snake.
Yeah. No, the first picture, you can see it. In the negative shadow.
That's what I'm saying. This is a...
All right, we got to move here. So IVUS is ready? 018 IVUS?
Yeah, it's set up.
So now your strategy is once you have the IVUS in, are you going to start treating this segment or just keep the wire in, go after this left iliac, try to cross?
Well,
I think we should keep the
yeah,
wire
we're going
in.
to keep the wire in.
No, what I mean to say is like, are we going to advance, escalate to just Shockwave first on the right, or you just try the left, if it
Start
fails,
core
then just fix the right?
Well, let's see how the IVUS. What the IVUS is not going to pass without ballooning. Wires out.
Right.
No, it's there. Okay, good.
Why is it? It feels like it's out. Like that's what I thought too.
Nice.
Part of
Okay. No, give us a 018. This
No,
one.
we're doing overnight IVUS or
018 IVUS, right? Yeah. So give us a V18. Go all the way up. V18. Good. Good. So we're just going to put a V18 up. Right. So with the V18 up now, we're going to start. So anyway, in the meantime, I want to just invite everybody. So our conference is set at September. September. Vishal, can you tell
12
everybody
to
the
18,
dates?
yes.
12
So
to
the
18.
12 to 18, Thursday through Saturday. Thursday will be mainly our endovascular fellows course, which is it's always been a hit and it's grown significantly since we started. So we approximately last year had like 83 fellows, and the goal is to have our core Mount Sinai faculty come in with some invitees from outside, have a good, nice, educative session, which involves cases, presentation, didactics, and all the stuff. So that's usually Thursday, and then our main conference
Give us the
is
035,
Friday and
the
Saturday,
IVUS first.
which is essentially based on all the
right.
faculties coming around the world, world-renowned,
IVUS.
with approximately 6 to 7 live cases, a lot of discussions, debates, fun, and cases presentation. So this time we'll be doing right in Times Square at Marriott Marquis. Great place to hang around, have some fun before and after the conference. So we love to, the official website will be updated with the agenda by the end of this month, but we are all more excited to invite you all. And once the registration link is up and active, but we'll keep updating you on the progress of the course as well. But our Near Endovascular Summit, September 12th to the 14th.
Hold on.
Okay. So we're going to do IVUS now. So we got the IVUS is there, and the sheath is back or what?
No.
Oh, sheath is good.
That's all right. It's just.
All right, good. Wow.
Let's see if the IVUS crosses. It may be tough. There it goes. Come on.
I think it went through. Yeah,
All
yeah.
right, good. All right, we're
Smooth
in the order
slick,
now. That's fine. All right, record. Okay, go live on the IVUS. Okay, recording. Pull back, Dr. Guja. So we're pulling back slowly. So Dr. Guja is pulling back. You can see the aorta is very diffusely calcified, as we told you. Some minimal, non-significant stenosis. Distal aorta is extremely large, and there's the ostium of the iliac.
Yeah.
Oh, there it is. See? Concentric calcium. Come back, Karthik. Lot of crud, and then back into the true lumen there. Nope, you went up and then came back down. Now it's all crud, and there. That's the, measure that, mark that for me. That's what we're going to measure it. And then pull back, Karthik, a little bit. And then there's your internal bifurcation, and we're out. Okay, good.
Beautiful.
So this side is done. Let's load the opposite side, the catheter. Ray, pin that wire for me with something.
Yeah, I have it.
So now on the left side, your strategy is again same thing, 035 up front, and then.
No, I mean here I think it's aneurysmal, so I want to be a little bit more careful. I got to be very careful on this side because it is aneurysmal.
Correct.
So get me a vertip catheter on this side.
Yep.
And then we're going to try to cross, and then God willing, we'll be done in a few minutes. If not, like I said, we're ready for the fem. So with this, Vishal, Karthik, looking at this IVUS, what's your vessel prep strategy here, Bhai?
I would definitely use Shockwave here.
Because of the calcium, Karthik?
Because of the calcium, but we're definitely in a plane for sure. So I would not be too aggressive with our.
Well, I don't think we're in a plane. I think we're true luminal. It looks good, but
I think one place it looked very eccentric, like
eccentric,
But that's because of the calcification per se.
The calcium,
I would just use like 6.0 Shockwave, and then I would just direct stent it, and then crack it. I would.
That's good right there.
Yeah, I think that's a good strategy. As you know, the IVUS pass, so you don't really have to pre-dilate much. Hopefully, the Shockwave being bulkier, but the 6.0 should cross on an 018 system. And then you're right, Shockwave it, and then you just cover stent in, and then you can crack it open as much as you can. But you're right, it's very
DSA?
eccentric, very calcified, and a lot of Goomba in there. So it's the
Yes, sir.
combination of the perfect recipe
Oh, hold on.
for disaster
Yeah.
if not done right way. But
So
yes,
this is going to be a little bit of a problem. Go forward,
correct.
Karthik, for me, because of the tortuosity. So he's going to make it point up.
Yeah.
All right, now give me the Confianza wire. So you're going to see here we're going to have a little more trouble with than the other one because of the curvature
Angle,
that you're going to
right.
have. So because of the curvature, I'm just going to make it point like that.
Yeah.
And then we may actually go with an IM here rather than a vert tip. We may switch out. Let's see how this wire behaves. Based on how it behaves, we can point it up. But let's see, or a JR4 may not be a bad idea either. But that's a good position that Dr. Guja's got us to. So let us see here, and then we'll take it from there. ACT was what, gang? 227. And sometimes what you want to do, guys, when you get close like this, you want to pull the catheter back and probe with the wire. So I'm going to pull it back here. Let the wire kind of try to find a lumen here. And sometimes it does, sometimes it doesn't. See, so it's kind of struggling to find that lumen. So I'm going to have Dr. Guja push up again and maybe torque it to point up like the other way torquing. Yeah, he's torquing it, so we're both working against there. There we go. It's kind of posterior there. Yeah. So I think this may be and maybe here, Vishal, maybe this is where you go with the glide. So give me the glide here, guys.
Yeah.
Angle catheter here.
Correct.
Well, let's try with the glide a little bit, and then we'll decide. Because here, 035. Because here, what I want to do is get close to the ostium, and I want to show everybody where the ostium is. So you can see here from above when you inject, see, it's right there. So
Right.
I have room to go here. So what I'm going to do is I'm going to dissect up and make sure that we're close and not, hopefully, I mean, if everything works well, it just goes right in and I look like a genius, but I don't think it will, but we'll see, So calcium is going to prevent me from getting into different planes here. So I'm going to pull back a little here. Yep, just like that. And then I'm just going to allow the wire to kind of form and then allow it to go. But again, you can see, there it goes. It did something cool there for me. So I'm going to have Karthik push up a little bit here. Good. So now I'm going to ask for a torquer. And then with the torquer, I'm going to try to kind of spin it up to the area of the thing. And this is where I think 035 systems help, So let's see how this works here for us. Didn't work.
If it makes that bend, Vishal, actually this crossing might be easier because the vessel itself is very aneurysmal. So it's more like probably a chronic thrombotic component.
But remember, you
here.
got to be very careful with these aneurysms. These aneurysms are very
That's
funky.
a good spot.
I know, but let's see if it goes.
That's good. That's good.
Let's see if it just goes a little bit for us.
It's a good spot.
I'm just trying to just finagle it up.
Yeah, I think the curvature is what's your enemy in this case. So it's just the way the angulation is. It doesn't really point up all the way. So you're right. It's just pointing into the wall rather than just going up. So
yeah, this is going to be an issue for us.
You might need an angle catheter.
Give us an angle catheter here, guys, like a
JR.
JR.
Yeah, I think I would take a JR.
New.
No, Lima catheter is better.
Yeah, it had a smaller hook.
IM.
IM catheter, just a 5 French IM is good. Yeah, because you're right, PK is just, if you get a little bit of traction into that CTO's part, and then you can actually track your catheter in and then exchange whatever wires you like.
Pushing back here just to get the catheter out, and then we'll go with the IM to make it point up. So here you can see the severe calcium, tortuosity. That's another reason why I chose the right versus the left.
Yeah.
Because I think, like I said, it's more of a favorable cap for us to try to get through. ACT, Ray, can we check another ACT, brother?
Vishal, what did you plan to do after this?
All right, let's give another 500 to 1,000.
Yeah, I think your strategy is perfectly right. Have a better angulated catheter, get a little bit of, let the wire hook up into that CTO segment.
That's the collateral.
And then try to see if you can get a little bit of purchase. So that way you'll get it. But you're right, the angulation is what is the biggest limiting factor. Even though calcium has always been an enemy, but in this case, more of an angle that's restricting your wire getting it.
Okay, there's our IM helping. Again, getting it. Now what I'm going to do, guys, you got to be careful because we're dealing with an aneurysm. So what I'm going to do is I'm going to go from above with a little die. See, I don't like the way that's pointing lateral. You can see how it's pointing lateral.
We can pull back just to touch it.
Well, let's see how the wire behaves.
Yeah.
And then we'll take it from there, right? So the wire. So.
It makes a full bend.
Yeah, no, I'm trying to make a turn here. Hold on. There he is. Let's leave it there. Oops.
You have to turn it in that bend.
Uh-huh.
Yeah.
Now you're pushing.
No, I'm not.
There you go. Now push the catheter
Yeah.
up.
Wait,
Uh-huh.
you want to turn that?
Let's see where this wire
No, but the
goes.
wire, yeah. No, I don't.
Let's see whether we can turn a little bit. Hold on. Let me just try to. There you go. Flip it up. Okay, good. I like that right now. Now give me a little diaphragm. Let's do a little picture. Ready? Inject. Uh-huh. Okay, I'm okay with that.
Yeah.
You
Yeah.
guys happy with that?
good.
I'm okay
Yeah,
with that.
I'm okay
Yeah.
with that.
So I'm gonna get a. Oh, it went to the side. Okay,
Wanna do-
torquer.
Yep.
So since it's going to the side, it's going to the side of the
straight,
worst.
there's a lot
No,
of
I'm just
torque
gonna
in
try to pull straighten out my curve.
What wire do you have, PK, right now?
It's an 035. There you
That's
go.
good.
035.
That's good.
Can
That's
I
good.
pull push up, Karthik, if you can? No, right? Not enough.
No, not
purchase.
right now. No, not enough purchase. I don't think.
Yeah.
Want to take your torque
gonna
off
flip
the
out.
catheter?
What?
There's a lot of torque.
Yeah, I
on
know.
it.
Yeah.
Take the torque off the catheter. I think
The
it'll.
other way.
There you go.
That's better.
Thank you, Karthik.
Yeah. Nice.
That's perfect. So now let's see if it just slides up for me.
Want to drill it through.
Oof.
That's good. That's good.
No, that's in the aneurysm.
Still okay.
Okay, give me an 014 wire here.
114.
Give me, leave it there for me now. Give me a Confianza here, guys. So in a few minutes, hopefully we'll be through this. Again, it's a little tougher. You can come from the arm. Okay, from the arm. But why not radial here, Karthik? So he's got, go ahead.
The only reason why not radial is for him is, first of all, it's aneurysmal. That's your biggest problem here. So when you poke from, the right you can approach always from radial possibility. The left is taking that bend from radial. It's very unpredictable. You might go through and through the lumen. You might actually rupture that aneurysm. For this case, I don't think radial is very feasible. That's one of the reasons. The other reason is left radial is occluded. So from the right radial, it's too much of a trip from the right radial. But you can do it, doable, but I would not approach this
Okay,
from
I like that.
radial.
Let's take a picture from above.
Ready?
Vishal, would you try it radially?
No, like from the beak perspective,
Nope,
the distal
not
beak
there.
looks much better approachable than this. And I also don't know. I know he's a hemodialysis patient. I don't know where the fistula is. It is in the forearm. Is it in
It's
the
on the
left?
right side. It's in the left side.
Yeah. So the left side is already out of picture to get
out of
access.
picture.
Now
And
you
also
have
the
right.
left radial is occluded. So
Yeah. So either we do right radial, try to poke it through there, but still obviously work from the femoral axis. But in this case, femoral would be the right strategy to begin with, especially the way we have the distal cap. It is looks a little bit more favorable. Based on just the anatomy, if you talk about the C-top classification, so it looks a little bit more favorable. I know the bend is giving a lot of trouble to PK. That's another thing to look into. But yes,
that's good spot. And
Yeah, so I
also
think it's-
from the radial, your bailout options are very limited.
yeah, exactly.
That's your biggest problem
Nice.
with
Nah, I
radial.
don't think it's good.
Why not?
I'm not crazy there. This is like you get one shot to cross where you want to cross, right?
Right.
So,
That's good spot.
I know, I'm just trying to.
So that's an 018 wire you have now?
It's
014.
Confianza.
Unconfident.
014.
Okay. Yeah, maybe a little bit more. It's just finding the lumen, I guess.
I'm just trying to play and find the lumen here.
Yeah.
Okay, let's go there, Karthik, for me for now.
You want to puff
Right
a
there.
little
Let's
bit?
see. This may be it. Okay, one second.
Yeah, this might be just the
This is
occluded
better, yeah.
aneurysmal. Yeah, it might be
This
just
is
the
better
occluded.
for us. Yeah, we're in a good spot. Okay. Let's pull back the catheter, straighten it out for me a little bit. There you go. I like
good
that.
You don't want to lose. Yeah.
Come on. All right, give me a little bit. Give me the Turumo, not the gold. Give me the Navic, the other one, the Turumo angle glide. It's very tight here, guys.
Angle glide.
You could also upgrade it if you like to an Astaro or a Win,
No, but I
stiffer.
think in this one, it's it's really not fun here because we're just trying to get it closer, and dealing with that aneurysm is making a
Correct.
pain. But We'll
That's
be okay.
true.
You give me a torque
My
on
only,
this?
my only concern, I guess anybody has to be careful is once you put an 035, it might kick your catheter back out, and then you might lose all the ground you purchased. So that's the
I
only
agree.
thing.
I
To
agree.
be a little bit,
Yeah.
I mean, not in your hands, but just from an educational perspective, we always have to be careful. So all the hard work can go out.
good.
So that's
I
why
like that too, but I just wanna
probably
make sure.
sometimes upgrading it might also work. But
Yeah, I'm
That's good.
okay.
I like that.
Yeah.
Take it closer,
nice.
Karthik. Uh-huh.
Yeah, sometimes, I think we might have to dissect it through.
Correct.
We might have not much of a choice
Pull
on
back
this
the
side,
wire.
only because it's a.
Okay. Now give me the torquer. Let me
Don't
see.
lose a loop again.
I want to lose a loop, don't you think? Yeah, I want to
not,
here.
Not here, no.
Yeah,
You
there
want
you
to
go.
get it?
Let's see whether we can.
No, you went back into that plane. That's
Yeah, I'm just trying to see whether I can.
Once you get the catheter closer.
There you go. That's the plane right there. Ah, jeez. That's not going to be it.
Don't you want to take the loop and get the catheter closer and then try with
But
confluencer?
but
just
you
like
see,
the other side?
no. But the problem is this side. What happens is the IM cat. We have to switch catheters. Then, if you want to switch catheters, I'm okay.
I think so. Make a loop and we'll switch
Yeah,
a
we
catheter,
can switch
right?
a catheter. See,
Yeah.
right there.
Yeah, that's fine,
Okay.
no?
Now we can switch.
a
Get the
catheter.
vertib catheter, guys. Hold on.
Yeah. The
I think,
Yeah.
So now you're in the aneurysmal segment, correct? If I'm
Right.
not
Yes.
wrong. The way
That's
it
what we
hits,
think we
yeah,
are.
looking at the wire. Yeah. So that's again a good sign. You're just abutting. So you have a very short, I know it sounds very short CTO segment, but a complex short CTO segment.
So we use the
Right on
vertib
the left
to get
side.
where we need to go. Now we're going to go with the. I mean, we use the IM to get closer, and now we're going to go with the.
And the tortuosity in the iliacs is what making
It's
it difficult.
killing us.
It's
Yeah,
it's
yeah,
making
yeah.
it difficult.
Why?
Give me a 20, a start of 20.
And the calcification, so. You want to be on this side, no?
Yeah. Well, I just want to get it close, and then we can manipulate it, right? Let's see, it's not going.
Yeah, this is going to be tricky. It's going to push through right there. Nice.
But hopefully, okay.
This is good. I like this
I
one.
hope.
Yeah.
You want to take a Terumo
All right, give it another 1,000.
Excellent. So now at least you have good purchase. A catheter support is there.
Yeah, I
Yeah,
mean,
try it.
it's going to be a. Go ahead.
That's a good spot.
Yeah,
Yeah.
I like that spot too. We just got to make it go up, and hopefully find our way in. We'll, God willing, let's see. And I have no problem pulling the catheter back to rewire in a different manner, right? So,
That's good. I like that.
yeah, we're crossed.
Yeah, we are crossed.
Nice.
Beautiful.
Nice.
Wait, hold on.
It's good. It's good pick.
Yeah, I know. I just want to make sure. Okay. Okay, good. Now,
It went in.
yep, it did. It popped in.
catheter.
So now we going to advance this. Oh, wait.
Okay.
Very nice.
Okay, go. It may pop. Nope, not popping.
Yeah, same thing.
Okay. 018
Okay.
Trailblazer
Yeah, same
or
thing.
118. We have it.
Navicross, yeah.
Navicross.
Navicross.
And then a quick IVUS, guys. Okay, so
Nice
now
job,
we
okay.
crossed. So now we're going to get the Shockwave. I gauged the 5.0 Shockwave, so I kind of want to stick with my guns here. Let's go with the 5.0 Shockwave after the IVUS on the right side. So, Ray, if you can set that up for us and get us another 018 018 wire on the other side. So I know we have an 035
V18.
right now. We need to change the other one out for a V18. There you go, bro.
Nice. So yeah, I mean, you can see a beautiful demonstration of just patience, finding the lumen, exchanging wires as needed, going up, going down, upgrading, downgrading, and then finishing if crossing a lesion was greatly demonstrated by
And then
Dr. Guja and Dr. Christian. So
I need a 035. We're going to change out the other wire to an 018 as well for the Shockwave, 014, I mean. So Dr. Guja rightfully asked for the Spartacore, which I should never doubt him, and I did. Go up again. And so we'll get the Spartacore ready on the other side. Go up. Okay. Give us 2 Spartacores. That's all we need now.
Okay.
2 Spartacores.
nice.
We can clean this up.
So we're planning to use a fiber shocker, right? Is that correct? PK?
5.0 Shockwave on the other side, and then I think we're just going to do two VBXs. I haven't
I
got
agree.
my measurement from the other side, as to
We still have to
where,
IVUS it, yeah.
where the sizing of the distal vessel is. I sized it as an 8. I don't know what they're going to say, but based on what they're going to say, we'll decide.
Right.
Okay,
And I think
Vishal, the biggest thing is I wanted to point out. I think that's the point. I think PK was subtly making that point that you should lose the loop. The place where we enter, I think, makes a lot of difference, especially if you're trying to create a bifurcation stent. So you don't have to create a carina into the aorta. I mean, we might have to create a little bit of carina into the aorta.
A little bit, not much.
Yeah, but you don't want to be too. No.
Yeah, I got the wire way up.
Yeah.
Wire's way up, yeah.
Yeah, I think in this case, I would not, I mean, personally, I would not be aggressive enough just to park it like a V to keep the carina in. For long-term patency, for good outcomes, not missing the ostium, because after so much hard work, I would just cross over into the aorta at a safer landing zone, not too much like you said, but definitely not be concerned about that. So,
yeah, I think the way PK crossed, it's very favorable for V.
Correct.
So what we're going to do now is we're going to clean up our table. I think that's important for everybody. You know, keep your table clean, because obviously now you're going to start ballooning. You're going to have multiple catheters, multiple wires. You know, so I'm just going to help us keep the table clean here.
See, at least PK is subtle to the fellow. He's just indirectly saying for the table to be clean. With me and Karthik, he's like straight up, straight front.
No. So you know what? One of the things I want to talk a little bit about is the symposium, and let you guys know. So a couple of things. I want to invite all of you to come. We're doing a lot of wonderful things. So we're going to have live cases from Leipzig as well as Dr. Metzger has agreed, Dr. Fadi Saab has agreed, you know, and maybe we have waiting for Dr. Montero to let us know, as well as our team from. That's it. Perfect. All right. So we're going to do a pullback here.
Beautiful.
So recording the IVUS.
Yeah.
So pulling back, you can see the other wire there. There's a little stenosis right there. That's the ostium. Right, and then we're going to come down.
Ostium right here.
Yeah, ostium right, and there's the aneurysm like I talked about. So it's just
That's your
and then
ostium.
there's the ostium again, and there's the aneurysm.
Yeah.
Keep coming, and then you can see again it's all stenosed. It's aneurysmal and stenotic.
Wow, look at you'll see a lot of plaque and thrombotic component in there from the aneurysm.
That's the landing zone. Okay, good. Okay, good. So let's change the other one out for an 014 now. The Spartacor on the other side. So put a 035 catheter up. So what was the measurements, IVUS team? IVUS team measurements?
They're like 10-0, wow.
Is it 10-0? I don't think so.
No.
It's not.
It's a 10-0, yeah?
9-0.
Yeah.
Yeah, we're going to go with, we decided, CT-wise, I'm going with an 8. I want to know the distal landing
Correct,
zone at the
distal
level of the
landing zone.
external.
Yeah.
External.
Yeah.
External, I know on the right is maybe a little larger than the left.
What time might not go, bro? Let's
Navi cross?
Yeah,
I didn't have it.
8s are good. 2 8s are good.
Yeah. I think, with the 7-2 and a 7-8, probably an 8 OBBX.
Huh?
Yeah,
Or
I think
longer.
so. 2.8 OBBX.
Yeah, 59s? Okay.
So Vishal would,
I think it's
stick to, you always stick to VBXs on this side?
I think in this case, VBX responds very well, especially in the common iliac segment. And of course, upsizing from an 8-0, you can upgrade all the way to 12, 13. So I think it works very well in this case. The only thing of course...
Would you go with bare metal stents, Vishal, or would you ever try bare metal stents on this?
No, I don't think, especially with the amount of thrombus, GUB, CTO, calcification. I think all these factors are indicative of using a covered stent as compared to even trying using a self-expanding stent. God forbid there is a distal edge dissection or something, and I know there's an external coming which I want to preserve, that I might think about it. But clearly the IVUS gives you substantial information. CTA adds on to that information. That covered stent is the treatment strategy in this case for sure. So I think it's a very good idea, and this is one of the great examples of how IVUS gives us so much information which we need. So sizing from all the way from sizing a shockwave to balloons to stentings to the degree of stenosis, calcification, and the treatment strategy. So definitely should be used for sure.
Yeah, the other thing, Vishal, is that Gore has come out with VBXs that larger sizes with smaller French sizes. So now we're planning on using an 8-0, which now can go through a 7-0 catheter, all right? Right, which is, I'm so sorry, I got to talk to these people. I don't want to give the wrong information.
The 6 O's and 7 O's can go
Can
through
go
6
through it.
French.
Yeah, but
Yes.
I'm talking about regular 8Os.
Okay.
Yeah.
6 O's and
So
7 O's
8O
can
39 can go through a 7 French, 8O longer. There's
Yeah,
an L,
8O
yeah.
long, the 59s are going to go through an 8 French.
8 French. 39 can go through a 7 French.
But so therefore we're going to do this. So here we're now going to do Shockwave, and then we're going to take a picture, and then we're probably going to go with an XL here, I believe, right? They're probably going to go with an XL 59 is what I'm thinking. So we'll decide. Yeah, so we're going to go with an XL 59, but I want to make sure we have them. So we're going to go with the 59 on the right, and then we'll decide on the left. But we're still further a long way from that. So we're just checking an ACT, Ray's checking an ACT. We're now going with the Shockwave balloon.
I'm going on the right side first.
Why?
Yeah, we're going to do it on both because there is component calcium on both.
Yeah.
But first we'll go on the right, and then we'll take a look. So you can see here the catheter is below. We're hemodynamically stable. A little bit more going to the aorta. Yeah, there we go. We'll pull our pigtail back a little bit, I guess. Yeah, just a little bit, just to have it back. Just so we're not. The wires are fine. You keep worrying about the wires. Yeah. Yep. So yeah, it's not going to be the carotid. Yeah, good. So we're back with this things. So now we're going to go ahead. Ready? Are we on coronary?
Hold on.
Hold on, off floor. Okay.
Coronary.
Okay. All right. Ready? We're getting ready to go.
Yeah, nice.
Go to what? 2 atmospheres, right?
2.
Right. So 2,
It should be 4 and 6 for a 5O.
4 then. 4 atmospheres. Okay. Good. All right. 4 and then Shockwave.
Yep.
Good. Press the button. So we're going to deliver probably 2 or 3 therapies here,
Yeah,
and then 2 or 3 therapies on the other side.
I think I agree. Yeah.
And then, I think it's a really good synergy with Gore. We're going to wait for it. No, you got to go back up to 6.
Yeah.
And then
6
I want to
and then
deliver
go.
at 6 as well, because it's undersized. I just want to expand the concentric calcium. So here's
Yeah.
the...
Exactly. So I think the usage, again, the sizing of Shockwave, the reason, I mean, somebody might say, 5O in an iliac, but it's all about the lesion and the apposition of the emitters to the lesion itself. The idea is to cause those microfractures in that calcium, and that's why he chose 5O, because opposing to that calcified segment gives that energy as well.
Now, and we're going to do a DSA. Let's go up here. Let's do one.
Normally, we can use Shockwave nowadays, comes in higher sizes, 8, 9, 10, 11, so we can use those, of course. But in this case, I think 5 or a 6 is appropriate just to get enough luminal gain as well as causing their lithotripsy effect as needed. So I think it's a good strategy. And
So Vishal, question is, would you come across that bend to the level of that internal iliac?
so
No,
I think
we have room to land it
On
above
this
this.
side,
Right.
we might not have room to land. That side, I think we
No, I
have.
think we do. We're going to be fine. You'll see. Go.
Yeah,
Yep, Flora.
I think we'll start after that collateral in the aorta, the big lumbar collateral, and then try to, I mean, again, the length, the issue with is you have a 39 and a 59. So depending on how far in and out you are, you might have to just, if it falls short, ideally we would want it before the bend. But if the length is too short, and then you might have to take the bend in your covered stent arm, which I think would not be an
Ready for
issue.
picture? DSM?
But ideally you would want to avoid it. But I think that's a good thing.
Don't inject from below.
But once you take
Just
pictures,
above. Cindy?
you'll have a very good idea of how the vessels are behaving.
So you have
But
plenty of
there-
room to land it.
Correct.
Have plenty of room. We'll be fine. Okay, Flora.
Beautiful.
Okay, we're going to go on the left side now.
So I think that's another great strategy.
So
Just
pressures
doing
are
two-way
solid. Now we're going to go ahead with this one. So
the left side. Yeah.
Yep. Let's go with the
Beautiful.
left side.
So I think that's a great strategy of getting the shockwave on both sides using the same emitters. So yeah, perfect.
Fine.
Excellent. And what's the status on the on the internal iliacs? I think
Both are paid.
Both are
both are
patent.
paid. So that's good. So yeah.
They both, actually,
That
the
gives-
collaterals are coming directly to the internal iliac.
Yeah. And I think we should technically preserve all the internal, like PK talks about, a big importance of the collateral vessels to the lower flow, how the lumbars, the IMAs go all the way down. The lima goes to the IMAs, goes to the lumbars, goes to the internal, goes to the profunda down. So I think it's very important to preserve these collaterals as much as they can. So,
you're good.
all right. So we take the shockwave on the left side.
Might have to go up a little bit.
Yeah, just have to be careful. It's an inflated balloon.
Four.
So, but yeah, right there. Beautiful.
So would you worry about the collateral supply here, PK?
No.
Vishal, would you worry about the collateral?
I mean, it's like I would like to personally park it. Remember, we still have area of normal segment below the lumbar collateral, so I would not want to
No, but there's no
cover it.
reason to go to the number. What are you guys talking
Right.
about? There's no.
No,
reason.
there's much
I think
below.
What
That's
Vishal is talking about
No.
is the collaterals coming to the internal. Down.
correct.
Okay. Push it up a little.
No, that's what I'm saying.
No,
we
no,
have
yeah.
enough reason.
But
I mean,
there's
enough
plenty of
room.
room.
Correct.
Yeah,
we have
you go-
enough room. That's what I said. We have enough room
Yeah, there's plenty of room.
to put the covered stent in and still spare the collateral, which you should always spare. That's exactly what we were talking about.
Would
so,
you
yeah.
would you even go into the aorta? No, right?
No,
Yeah.
slightly in the aorta, just to
Yeah.
cover my ostium, but not like
Yeah.
maybe a half a millimeter, not more than that. I mean, we crossed beautifully. IVUS shows we're good. I think we're fine. We'll take a look. We'll take a picture. We'll know. We'll know in a second. Okay, down.
Cool.
Okay, down.
8 and down.
Okay,
Back-
we're gonna walk
back
back now,
Yeah.
and then
All
let's
right.
take a picture. All right,
I
ready
don't
from
think
above.
I've covered the distal end.
I think we'll be okay there. There's no
Yeah,
reason
we'll be
there.
fine.
Ready, Cindy? Inject. Okay, there it is. Okay, we got to open that up a little bit. Just a short
Yeah.
segment. So on the right is going to be the longer stent we need, Mike. So I'm thinking here. What?
I would do one.
59.
Okay, let's go up here. That's fine. I think this makes sense to do one here.
Yeah.
So 8059 is okay
Well,
with you
8.
guys?
8.
8.
Okay.
I'm gonna go in a little bit more. See the neck here, right there.
No, we're good.
Four.
Yeah, we're
Okay.
good. We're good there, Vishal.
8059 on the right and 8039 on the left. Okay. 8059 on the right, 8039.
8:39. Yeah. Both 8:59.
Well, no, when 8059, when 8039. Down?
16. And down.
Yeah. Okay, let me walk it out.
Which side are you putting?
I think the
8:59?
left.
On the right.
Remember, there's a it's a 560. Right. What length shockwave is this? 580.
It's a 60.
60. Yeah. So then a 39 on the left, I think should suffice.
Well, we'll take a look.
Yeah.
Definitely.
No.
I don't know.
I don't know. I think I would go with 59 on both sides.
That's fine.
No.
You can go for 59.
This is a
but
60 balloon, right?
No, hold on. Watch out. Let me see. Do one picture.
Because the internal iliac on
Okay,
this side is
inject
very
from
low.
below and above, guys.
Take this.
And get some cc's of syringe and inject here. Ray. Okay.
I got this.
Here, you inject from above.
Yep.
Hold on a
I
second.
got this.
Hold on.
Yeah.
Hold on. Just want to prep up here, make sure no clots.
Yeah.
Okay, ready? From above and below.
Ready?
Ready? So you're going to inject from above first. Let's fill the catheter. Okay, good. Ready?
Yep.
Above first. Below.
Boy, I need that internal. Wow.
Yeah, that's a huge internal.
Yeah.
I
Yeah,
think
yeah.
you go with a 59. No way.
No,
39.
39.
39.
Yeah, one more second. We'll go another.
And I
view.
think,
We'll
Karthik,
look
this is where your point comes in, that
One
if in
more?
distally you think your external is disease, you can put a self-expanding after that.
Yeah.
And then can still spare your
I think this
internal.
is where the point comes in. Listen to the old man in the room. Ready?
Hold on. Go.
All right, ready? Eject. Yeah, see, it's coming off right at that at the
39
spot,
is fine.
guys.
39 is fine.
It's coming off right at that.
We can always put a self-expanding.
So we really got to think here because we got both the osteums involved. We've got both the external iliac involved. It didn't look like that in the CT. It looked like there was a landing zone in the CT. So to me, right now, I think we should do one 8039 and one 8059.
Yeah, just like you
So
said.
give us a 39 on one side,
I
59
hate to
on the
agree,
other.
but just like you said.
59 and 39. Yes.
Yes.
It's fine.
You can also see the right coming right off just before the lesion as well. So I think
So the other
That's one
question
thing
is, what view do you guys like to stent? You like this view?
Yeah, change
Scene
it
minus?
to 035.
No, this is 018. Scene minus? Scene minus? You can 018 stent. So.
Thank you.
I would use
What view do you want to work on? Do
I
you
would
want-
work on an AP view, like the
All right,
first
go
shot we
for-
had. No, this one.
Okay, let's
This
go to that
one.
first
Look at
shot
this
then.
one.
Let's go to the first shot.
This is one.
Okay. Let's go to the first shot. Ready, Flora? Okay. All right. Ready? Ready for a picture, guys?
Yep.
Ready? Ready, Ray? Above first. Inject. Below.
Work on this view.
Yeah, I think we work on this view. Okay. All right, 59 and 39.
59
Yeah,
is open.
it's a little tricky because you don't. The right external is right at where the lesion ends. So you just have to be a little bit cognizant of that fact.
Let's try.
So 59.
All right, 59.
I think you can
first, Dr.
park your
Gooch.
stents here, and then you can take a couple of diagnostics from both sides just to make sure the internals are behaving okay.
59 on the right.
Yep, thank you.
Yeah.
Ray, the venogram is done over there. Oh, you want to just take a peek?
Wire.
Uh-huh. Mm-hmm. Okay. Uh-huh. Good. A little more.
Wow.
Okay, good. Okay.
Yeah.
All right, we're across now. We'll just make sure from above. Got to go a little more.
I think it's a good spot.
Yeah? Slightly. Let's see what you're going to do.
No. A little bit more, I think.
There you go. I like
Yeah.
that.
Yeah, that's better.
Okay. Okay. Let's go the other one. Come forward. The other one.
You have
I'm actually going to go up
you
a
have
little
some
bit more.
waste on it, foreshortening, right?
No, only if you post-dilate.
Yeah.
39.
Wire.
Yeah. Beautiful.
All right.
Mm-hmm. We have to,
All right, get us an 018 wire, guys.
I see it.
Yeah.
Okay, actually, give me a 70 regular balloon, 70 40
Yeah.
balloon, 7040, and an 018 wire. Let's change it. 70. Do you have a 01470 or only 018, only 035? Give me a 014 and 01870 balloon. 7040. There may be a Pacific Plus, but it's probably too long. All right, so give us
Wow.
you don't need a picture now. You're good.
no, I'm just doing a dry scenario without the.
7040. Yeah.
70018.
Yep, and then we'll change the wire out. Give me give me a brand new.
The calcium.
Yeah.
I think it's hitting that bend.
Yeah,
Correct.
but we're gonna just go with an 018. Let's balloon this a little bit with the 70, and then
Yeah,
go.
I think it's right, just to give it so that the stent does fine.
Let's change out the wire before we do anything, guys. Give me an 018 wire. Yep. Go.
Yeah.
Real.
Go right.
Go. Good. Now give us an 018 wire. Wire out. Okay.
Every time I push him through that bend, he feels it.
Give me a wire introducer, guys.
Yep.
Again, guys, I don't want you to minimize the value of vessel prep, even if you have a covered stent. You know, these covered stents are great, but you still need to prep the vessel to deliver them as well as expand them properly. So now we're just going to advance this wire V18, get a stiffer wire up, which I think makes a lot of sense for us here. So there's my stiffer V18, it's fine. Now we're going to walk this back we'll go up here first, attach.
Yeah.
So let's go up slowly. So we're clearly undersized in the aorta, but I'm going to expand this here. Go up.
This is 39, right?
Yep.
Okay, nominal is 12.
No, this is not a stent.
This is the balloon.
Sorry.
Slow. Sinis, Karthik. Oh,
Down.
off. Put it on coronary, please. Okay, go up again. You didn't expand.
It did.
Yeah, you could see a tight neck right there when he had a drawn
I
out
did it. It's just a bubble.
Yeah.
No, it's not a bubble. Go up. 10.
10.
There it is.
That's it.
Okay.
Yeah.
Down.
Nice.
Let my floor say that.
Laura. Go up slowly here, not too much. Go to 6.
4.
6.
6.
Good. That's it. Down. Now take it through again. Yeah. Good. Down.
Yeah.
Okay, good.
Good. It's good. I think the
One more time, go up.
overnight.
Go up. No. You go up.
No.
Balloon. Negative. Advance. Good. Okay.
It's good.
Good.
I think it's the wire. I think we didn't expand the lesion completely.
Yeah.
I think it should take that time.
Give us the stent now.
A039.
Also, when the stent doesn't cross, always examine the stents.
Yeah.
Make sure there's no
These
evolution.
stents strip off
Yeah, all
and-
the stents are good here. Okay.
All right. That's good. Perfect.
Okay, good. All right.
Nice.
Now we need to advance the other one slightly.
Dry,
Yep, Liz, advance it slightly, Flora. Slightly up with the other one.
I think we're good,
Yep.
Yeah,
PK.
but
Got it.
this one's too high. A little bit higher on the other one.
No,
Thank you,
I think
Ray.
we are too high with both, I think.
Okay, let's take a picture. Cine?
Let's take a picture. Yeah.
No, I think we're good. I think we just need to come back. I'd go up with the other one a little bit.
This one?
Slightly, yep. Slightly. A little more. Now pull back
Let's go.
slightly.
Ooh. Yeah.
No, it's all right.
Yeah, it
a
just-
little- Okay, now go up with this one a little bit. Ready? Slightly. All right, I like that. A little bit too much. Let me come
much,
back a
right?
little bit.
Yeah.
Let me come back. Okay, a little more. That's good. All right. What does everybody think? Ready? Take a picture here.
Yeah.
attach
Let's
both.
take a picture. Yeah.
Yeah, we're going to inject from above and below, guys, okay?
Yeah.
So, ready? So, I got one, you got one. Above and below.
Mhm.
Okay, ready? Okay, sending from above first. Inject. Above. Below. I think we're perfect. Perfect. Everybody okay? I don't
Yo,
hear the yays.
I would pull back, PK.
Hold
No,
on. 1 second.
I wouldn't pull back.
Can I? Are
Yeah,
you
what are you
okay with the
worried
right internal?
Yeah.
I think we are okay there.
Yeah, we're
Vishal.
okay.
We are right above it. Yeah. My only thing is, should we pull back a dot?
I like it. Trust me.
I think it's
you-
good. I mean, I would
think
not
it-
want to
okay.
pull it back.
Ready? Both
okay.
everybody go up. Wait,
Yeah.
what's let's go up together.
Your nominal is 11.
What's your nominal?
12.
Okay, let's go. 1, going up, don't move the stents. 2,
Yeah, in this case, very important to
Sure,
hold
we-
both
we
the
should
stands
not
like
move the
Karthik is
song.
doing.
3, Karthik, move the stent.
Yeah.
4, 5, 6,
Yeah.
7,
Karthik is keeping traction on both
8.
ends.
9,
Wow.
10, 11.
Beautiful.
He felt it, felt
It's
it,
okay,
felt
it's
it.
okay. 11. 11. 11.
Yeah.
11. Leave it at 11.
Yeah.
Fluorescent, yeah,
1
perfect.
Mississippi, 2 Mississippi, 3 Mississippi, 4 Mississippi,
You know, counting
5
means
Mississippi.
no Mississippis.
Down,
No Mississippis.
right? Yeah, but down is fine.
Yeah.
We're going to go up
Got too
again.
excited
We always
with
go up again.
Mississippis, you know.
Ready? Again, we're going to go up again. We're supposed to roll this down. So wait, we're going to go up again. We're going to go one. I want to count it out again. Ready? Pressures are right back. So we're going to go up one more time.
Look at the pressure gradient
Right, 1
improvement.
second.
Wow.
Yeah, it's completely.
1 second. One more time. Ready?
Let it
Go up.
breathe. Yeah.
We're going to go up to 11. You ready? 1
Yeah.
Mississippi, 2 Mississippi, 3 Mississippi, 4. Roll it down. Okay. And then down.
Mississippi, yes.
So
PK's Mississippi counter now. you
I know. I was going to say what happened to. Good. I mean, that looks very good, actually. Let's see. We'll take a picture. We'll know. But I think it expanded well,
blue
positioned
is which
right.
side, guys? Is left.
Blue is right.
Blue is right. So
I'm
right,
moving
we
it.
still have a gradient.
I'm moving it.
I don't know. I'll probably
No, I
zero
don't know
everything.
about that. I don't know about that.
Okay, brother, you want to?
Yeah.
It's a long balloon.
Let's go
so
double
it's
negative
probably
with everything.
taking
Correct.
in.
We right now have
Is he
balloons in
okay?
there and everything. So.
Double negative with both.
Sorry.
There's no gradient. Gradients
No
are gone.
gradient.
Yeah,
So
to let the
pressure-
balloon breathe.
You want to
yeah.
walk out the.
Yeah, hold on.
right
Let me
one
first go to weight negative. Okay. Ready? Walking it out. Hold on. Okay, good.
Got
Now the other one. Negative, you went?
Yep. Doubled.
Uh-huh. Wow.
I think we still might have to.
Okay, ready?
One second.
DSA.
One
Tell them
second.
not to move, Liz.
1 second.
Hold on. DSI.
Okay. Ready, Cindy?
You on DSA?
Yep. Wow.
I have to put a stent, self-expanding stent on this side.
Well, we got both the internals are open,
Yeah.
right? So you can see the internals are open. So I think we just have to make sure we're IVUS appropriately matched to the distal there, and then we'll take a look. So let's do IVUS, guys. So
Yeah, it's
Vishal,
beautiful. Very
little,
nice.
a little bit about this. I mean, I think that it really showed that how Dr. Guja really perfectly placed the stents up top.
Without pushing or pulling.
Without pushing, even though I was teasing him. Everybody knows I was teasing him. But, the point here is that, the positioning of the stents are very, very important. And you want to get apposition. Now, the blood pressure is a little high, so we need to control the blood pressure a little bit. I know he's a dialysis patient, but we're not going to do anything right now because I think 213 is a little uncomfortable for me. So we're going to give a 5 of hydralazine maybe, right? We'll give a little 5 because I think with stent grafts in and we've now, balloon angioplasty to the CTO segment, I think 5 of hydralazine, just to get it in the 180s, I'll be happier. But we have no gradient. Now, why I'm doing the IVUS is 2 reasons. One, I want to look at the distal landing zone to make sure that we're one-to-one opposed. I also would like to make sure that if we need to add a self-expanding stent, if there's an edge dissection, we want to know as well. So right now, Dr. Guja is doing on the right side, then on the left side, and then we're going to decide. I think the value of intravascular ultrasound cannot be stressed enough here. Okay, so we're in the aorta there. So Dr. Guja,
Can we decrease the diameter a little bit?
Yep, and now we're going to do it. I want everybody in the audience to see. Can you reduce the gain? Thank you.
No,
increase it.
Increase it.
Yeah, that's 20, the highest. Yep, that's the highest.
24 is the highest.
So we're going to pull back now. You want to just make sure that it's a good flow, a good attachment. That's the contralateral wire that you're seeing. You can see as you come in, there's a stent in the aorta, beautifully in the aorta, well opposed, no infolding of the stent. As we're coming through the stent, I'm looking for infolding, I'm looking for diameter, any compression, and then at the distal edge, there you go. Beautiful, no dissection. You see that? So maybe a little mismatch distally or no?
Little mismatch.
What do you think?
Just a slide. Yeah.
So give us a short 9.0. Yeah, maybe a 9.0 balloon. What do you think?
Over 8.
Or now we just leave it. Yeah, I would just maybe leave it. Leave it at that. We'll decide offline what we're going to do. Let me see that mismatch one more time. Let me see how bad it is. Right there. Come back up.
Yeah, I went back in again.
Yeah.
Come back down. Come back down.
Down. That's it.
Come down. Yeah.
You know what? Yeah, get us a 9.020. I'm gonna go with a 9.020 distal. I want to pose it. That's a little uncomfortable for me. And then we'll go ahead and do the right side now. It's a good millimeter.
Wow.
It's not it's not barely off. It's 1 millimeter off, I think. Yeah, we're gonna flare it. So we're gonna hang this in the distal part, and then we're gonna flare it down. So, and now we're going live on the IVUS, please, on the other side.
Live.
Yep. So now we're gonna go. This is what Dr. Guja wanted to treat this with the self-expanding, which makes sense.
Yeah,
so,
we have to.
Yeah, we're going to treat that. So we're going to go up. Now, first, let's make sure our stents are okay.
Yes.
So, okay, there's the aorta. Up, gain, please. Yep, thank you. Aorta coming back. You can open that, brother. 9020 Armada. Yep.
Safe.
That's fine. Mm-hmm.
That's
Coming
your
back
stent
down.
right there.
The stent is beautiful. Again, all the things we talk about. No infolding, wonderful of apposition. And here, I think distally we're going to be okay, but we're going to land a self-expanding anyway here, maybe.
Right there, definitely.
Well, there's a little bit of, I don't know what that is.
Dissection.
Maybe a
That's a
dissection
dissection.
there. Come back now.
Yeah,
So-
it's a plane and a dissection.
So you have a lesion right
And there's
here.
a lesion right there.
Okay, so
External.
we'll do this offline.
Ooh, wow. Yeah.
We'll do this offline. Okay, so again, it's 9 o'clock. I just want to go ahead and sign off here. So everybody saw what we did. We're going to go ahead and we're going to do a 9020 balloon of the distal to oppose the distal iliac stent. We're going to do a self-expanding stent and maybe another Shockwave if Dr. Guja wants to do it offline of the left external iliac. Before we sign off, Karthik, anticoagulation strategy, dialysis patient.
I would just go with aspirin Plavix.
Aspirin Plavix 1.
That's
Vishal.
Aspirin Plavix, yes.
Okay, and myself as well. Surveillance, Vishal, what do you do?
Well, just do a repeat ultrasound in a month and follow the patient clinically. I mean, CTA, I do it maybe once a month just to see if there's any issues. But
Once
most of
a
the time,
month?
I mean, I'm
Once in a month.
After a month, sorry, not once a month. After a
Are
month,
you investing in a CTA center, Dr. Kapoor?
I wish. What I meant to say is after a month, but usually follow up with Doppler ultrasounds and clinically.
Wonderful. I think we all agree. So anyway, everyone, thank you again for your attention. I do want to shout out to Dr. Raman Sharma. We miss him terribly. I am very jealous because he's on vacation, but he's a well-deserved vacation. And hopefully him and his family are safe. And we will see you guys next month, right, Vishal?
Yes.
Can you shout out the dates?
Yes.
And I want to thank Liz for a wonderful nursing, Damien for his incredible teching, and our team, which again is incredible. So thanks again, everyone.
Perfect.
That's what you want.
So we're going to stay live,
Yes.
Vishal.
Okay. Sure. Awesome. Perfect. But thank you, everyone, for joining us. Whoever stays on can, of course, see our live cases in the archive. Right. In the archive section of our ccclivecases.org, you can see all our previous cases, including today's case. A great demonstration by Dr. Guja and Dr. Krishnan on a very complex bilateral iliac CTO occlusions using a role of IVUS, role of adjunctive therapy, and, of course, destination therapy, an important treatment strategy discussion. Thank you for joining us, and we're going to see you next month, which is March 27th on a Wednesday, 8 o'clock Eastern Standard Time for another exciting case. Till then, have a great week and a month ahead. Goodbye from New York.